Now, in terms of BMI, another lifestyle choice, there's certainly some consistent linkage between guys who are significantly overweight and obese and the higher incidence of infertility in this group. So when you're looking at your BMI, it's your height versus your weight. A BMI of 18.5 to 25 is thought to be healthy. 25 to up to 30 is deemed to be overweight. 30 to 35 is obese, and then, well, above 30 is obese, but there's subcategories within that of 30 to 35 class 1, 35 to 40 class 2, and above 40 is class 3. And actually, we know that a BMI of over 30, or obesity as it's classed, increases your risk of miscarriage, increases the risk of gestational diabetes, gestational hypertension, preeclampsia, and thromboembolism in pregnancy. And women of this kind of size are less likely to go into labour themselves. They're more likely to go post-dates and require induction. They're more likely to be delivered by caesarean section, either emergency or planned caesarean section. And in terms of postnatally, they're less likely to breastfeed successfully. They have a higher risk of postnatal infections and a higher risk of adverse neonatal outcomes, such as stillbirth, congenital abnormalities, and neonatal intensive care admission and neonatal death. So it's quite frankly obvious that this should be something that would guide policy in terms of fertility treatment. I don't think there's ever really been a lot of thought in terms of looking at cause of infertility with BMI, because it's very variable. It's not very easy to say, well, when you get to this weight or this BMI, that your chances of infertility are this compared to a normal BMI. But certainly if you look at pregnancy outcomes, there's quite strong data there. And when I was talking to Sarah before about the new guidelines brought in about reducing BMI from 35 to 30 for NHS-funded treatment, I was a little bit perplexed because I didn't really know of a lot of data that was out there looking at fertility treatment success and reduced BMI to that order and seeing whether there was any positive outcome in terms of reducing their BMI requirement. However, there's a really interesting landmark paper that's come out this month in the British Journal of Obstetrics and Gynecology, where for the first time they've looked at these three subcategories of BMI and looked at the pregnancy outcomes and looked at the neonatal outcomes. And actually it's quite interesting to see, whereas I didn't think there was a lot of evidence for the 30 to 35 BMI group, there is a lot of evidence to suggest that your risk of diabetes in pregnancy, your risk of hypertension, preeclampsia and so on goes up. But those risks are commensurate with your increase in BMI. So even if you're in the overweight group, you have a higher risk compared to a normal weight. But as your BMI increments up, these risks become more and more severe. And again, in terms of the neonatal outcome, which as a clinician trying to get people pregnant so that they can have a baby, so they can have a family, what you don't want is for them to go through all the heartbreak and the sorrow at the other end of that pregnancy because of risks and complications that you've sort of inflicted on them. And there's really quite a significant association with admission to neonatal intensive care following delivery for all of those three groups in terms of BMI. And looking particularly at gestation of prematurity, again, across all of those BMI categories, low birth weight, and perhaps not that surprisingly, macrosomia, which is very overweight neonates to the order of 4.5 kilos or above, and also low APGAR scores and stillbirth. So I think there really is some logic to that part of those criteria. And it's about having a holistic approach to the women and to the pregnancies they are embarking on.